The infraorbital nerve block will anesthetize in one injection all peripheral branches of the infraorbital nerve, the anterior superior alveolar nerve, and often, when present, the middle superior alveolar nerve. At times, pulpal anesthesia can be obtained from the central incisor to the mesial buccal root of the first molar. The target site for the injection is the infraorbital foramen. Although several approaches have been described, the vertical approach is the safest and most commonly used.
Before injection, it is important to locate the infraorbital foramen. When the patient is looking straight ahead, a line drawn vertically from the medial aspect of the pupil will overlie the foramen. The foramen is identified by palpating the infraorbital rim and feeling a notch or roughness corresponding to the zygomatic comaxillary suture. Then, sliding the finger inferiorly 5 to 10 millimeters will bring it to rest in a depression containing the infraorbital foramen. Anatomically, the pupil, infraorbital notch, and infraorbital foramen lie in a straight line. For a right-handed operator performing a right infraorbital nerve block, the clinician should be seated in front of the patient, with the patient's neck extended and the head turned to permit visualization of the right premolar region. The mouth may remain closed. The left index finger is placed over the infraorbital foramen, and the upper lip is retracted by the thumb, pulling taut the tissues in the mucobuccal fold. The needle is then inserted vertically, about 5 millimeters lateral to the second premolar and parallel to the long axis of the tooth, with the bevel of the needle facing distally. The orientation of the needle as seen from the front of the patient should mirror a vertical line defined by the medial aspect of the pupil and the infraorbital foramen. For this and other injections described in this program, a few drops of anesthetic, expressed as the needle is slowly advanced, is useful to minimize discomfort. The average depth of penetration is about 15 millimeters. After negative aspiration, injection is made with the palpating finger remaining in place to help guide local anesthetic solution into the infraorbital canal. A total of 1 milliliter, or about 1/2 of a dental cartridge, is injected slowly. As with all other injections, the needle is then slowly withdrawn. Because of crossover fibers from the contralateral side, anesthesia of the central incisor may be incomplete unless a supraperiosteal injection is made over that tooth. An important advantage of this vertical approach is that the overhang of the infraorbital rim protects the eye from accidental needle puncture. Distal orientation of the needle bevel during insertion offers two potential advantages. First, if bone is contacted prematurely, the heel of the needle bevel will tend to glance gently off the bone without scraping the periosteum. Second, the spread of anesthetic into the foramen and canal may be aided. For a right-handed operator performing a left infraorbital nerve block, the clinician should remain facing the patient, this time with the patient's head turned toward the operator's side. The left index finger is again used to palpate the infraorbital foramen and the thumb to reflect the upper lip. For the left-handed operator, the mirror image of the techniques illustrated in this video may be used.